Hi, and welcome back to this first video in the 11th lecture on Covidenomics. In the last few lectures, we've been looking at the impact of the pandemic on particular industries and businesses. In the last lecture, we started looking at the issue of data and the impact of data both on individual industries, but also the issue of data as an economic good. We got to the point where we said, well, maybe the government needs a data right. Access to data can help us battle the pandemic and may help us deal with, for example, a second wave. And if you've been following this course, you'll realise that a particular line of reasoning that we've been following is that initially a hard lockdown was politically inevitable, necessary to stop the hospital system from potentially being overwhelmed, but also necessary to learn stuff because we were dealing with a pandemic that we had very little idea about. We've then been following through on how to model the pandemic, how people react to the pandemic, and then how businesses react. But as I'm making this video, many countries in the world, particularly in Europe, have entered what we'll call the second wave, where the virus has taken off again, and they're trying to think of the policies to deal with that second wave. In the state of Victoria in Australia, the second wave was dealt with by another hard lockdown. But is that the appropriate way to deal with the second wave? The second wave isn't like the first wave. We've learnt a lot about the virus due to the first wave, due to getting on top of the first wave. So can we learn from other countries? In last video we talked about South Korea and Taiwan as two examples. Can we learn from other countries about how to better deal with the pandemic and, in a sense, for this particular virus, live with the virus, at least until there's a vaccine, or possibly, inevitably, that the vaccine will be temporary, it'll be more like a seasonal flu, where we have an annual vaccine. So we have to start thinking now longer term. How do we deal with the second wave? And longer term, how do we come to grips with living with the virus? That's what we're going to be looking at now. A key paper that we're going to be looking at is this one by Bakay, Fari, Mina and Stock, Policies for a Second Wave, which came out earlier this year in the Brookings papers on economic activity. I'm going to be mainly referring to the June 25 version of the paper. There is a slightly updated version of the paper that's come out in a conference volume. However, essentially the two papers are pretty much saying the same thing from our perspective. And the key importance of this paper is that it looked at different approaches to the second wave. In particular, it models how different policies can be either substitutes or complements to enable us to effectively live with the virus, to deal with a second wave and to avoid the pandemic taking off again in a second wave. What do I mean by policies as substitutes and complements, though? Well, remember from your first year course, just the definition of a substitute. If the price of good A goes up, and that means you buy more of good B, then good B is a substitute for good A. And I mean the same thing here. If one policy, for example mask wearing, becomes more difficult, can we then have less mask wearing but get to the same outcome in terms of the pandemic by raising some other policy such as social distancing? So if you think of it, if the price of mask wearing went up for some reason, is social distancing or closing down bars and discos or even a lockdown, are they substitutes for that policy that we can only do less of now? From your first year micro course, you know that a complement refers to a situation where if the price of one good goes up, you buy less of another good. So for example, if the price of bread goes up, you buy less butter. Price of bread goes down, you buy more butter. They're complementary products. I sort of mean the same thing here, but not quite in the same sense. Rather, what I want to get at here is that sometimes you need a group or a cluster of policies in order to get the desired outcome. In other words, mask wearing by itself may not be enough to cap the growth of the virus. Social distancing by itself may not be enough to effectively deal with the virus. But if you have both mask wearing and social distancing, then they might be enough. So really, when we're talking about complements here, I'm thinking about what packages of policies are going to be effective in managing the coronavirus, particularly in this second wave. The types of policies that we're going to be considering here are what are called non-pharmaceutical interventions. So they're not pharmaceutical, they're not medical, they're not drugs or hospitalisation or putting somebody on a respirator. Rather, they're non-pharmaceutical. They operate outside the medical system to help reduce the probability that somebody who is infected will pass that infection on to other people. So things like mask wearing, closing down particular businesses, stay-at-home orders and so on are all non-pharmaceutical interventions. And remember from the earlier lectures that the way these non-pharmaceutical interventions work is by reducing this parameter beta. Beta is part of our reproduction number for the virus, and beta is made up of two bits. The first bit is this value E, which is simply the expected number of people that a person who is infectious is likely to interact with while they are infectious. While the second part of beta is given by this P, which is simply the probability that when you do interact with somebody whilst you are infectious, you actually infect that person. A non-pharmaceutical intervention can affect one or both of these parameters. So for example, if we think of mask wearing, the whole point of mask wearing is that you can go about your life pretty much as normal but wearing a mask, so it doesn't change the number of people you interact with, but it does reduce your chance of infecting them when you interact with them. Conversely, something like, you're feeling sick, stay at home, get tested, that sort of approach, that stay-at-home order or quarantine order is really an attempt to reduce E. In other words, it tries to make sure you don't interact with anyone. So what sort of non-pharmaceutical interventions can we consider? Well, for example, requirements to work from home if you're able to work from home, requirements to maintain social distancing, so keeping a minimum distance between yourself and other people, encouraging or requiring personal hygiene practices, so for example, washing hands much more frequently, wearing gloves, making sure you don't touch your face. One that we've talked about a few times in this course, mask wearing, requiring schools and businesses to close, remembering that there can be a whole range of varieties here, and we've seen a variety of versions of this intervention, not just in Australia but around the world. So for example, you may close schools completely and require distance learning. You may close schools to certain students whilst other students can still go to the schools. You may have a situation where the schools rotate between allowing some students in on one day and different students on alternating days. Other simple practices that schools have done to try and intervene in the spread of the virus, having staggered pick-up and drop-off times for students so that there's less interaction between both the students and each other and the parents and each other. Similarly, there's various versions of business closures. For example, in the first wave, there were essentially no restrictions on construction in Melbourne. Despite the issues with the pandemic, construction was essentially able to continue unhindered. That was very different in the second wave, where a range of restrictions were put on the construction industry. And more generally, you can think of the closure of bars, of clubs, of gymnasiums, for example, as examples where there's been more stringent business closures. There can also be a variety of other workplace restrictions. For example, requiring a minimum of a certain distance between workspaces in an office, only allowing a certain number of workers to be in an office of a certain size. In other workplaces, most obviously in retail, having other interventions required, for example, requiring that there are perspex screens between anyone who is serving you and the customer, requiring that there are only allowed to be non-cash transactions so that the virus isn't surface transmitted through the transfer of cash. Restricting visits to aged care facilities is another non-pharmaceutical intervention. Obviously, that is one that is focused on protecting the older members of society who are at most risk of significant health problems and death from COVID-19. And again, we've covered that off in the earlier videos, how this was one of the factors associated with COVID-19 that was understood very early on, that unlike, say, the Spanish flu of 1919-1920, which tended to affect the whole population, but actually affected younger people, people in their 20s and 30s were more at risk than other groups. For COVID-19, it's been very clear from very early on that if you're in an older cohort, for example, over 70, your risk of death from the virus is much, much higher. Another key intervention that we've talked about quite a bit in this course is testing and quarantine. So testing and tracing and quarantine and the way that that's enforced. And we've indeed looked at South Korea and Taiwan in detail on these last week. You might think, well, hang on, are these really non-pharmaceutical? After all, testing is, in a sense, pharmaceutical. You're testing whether the virus is present in the body, but it's not a pharmaceutical intervention in the sense of you are using medicine to treat or medical techniques to treat the virus. It's simply determining if a person has the virus, and if they do have the virus, requiring that they distance themselves, they isolate themselves from other members of the community whilst they are potentially infectious. And finally, of course, when we're talking about non-pharmaceutical interventions, there is the biggie, the general lockdown, the situation where essentially people are required to stay in their homes. They may be allowed out for a short period of time for exercise. They may be allowed out to shop, perhaps as in Melbourne, 1 hour per day maximum exercise, and not in the company of others, and one person from a household able to shop a maximum of once per day. So these are our non-pharmaceutical interventions, and they're going to have very different economic effects while they're all trying to achieve the same health effect. So the health effect is to try and reduce the number of people who are exposed to a person who's infectious, and if they are exposed, to reduce the probability of the infection being passed on. That's what all of these are aimed at. However, some will have economic consequences, some will have little economic consequence, some will have an in-between economic consequence. For example, a general lockdown or business closures, they're going to have very strong economic consequences. A general lockdown, obviously, having the strongest economic consequences. Business closures, well, it depends on which businesses, how many businesses. So just requiring, for example, that perhaps gymnasiums, indoor dining, nightclubs and pubs, requiring that they're closed, that's going to have an economic impact, but it's not going to be as big as if all industry has to close. So business closures is going to be an economic non-pharmaceutical intervention, as is general lockdown. Closing schools is also going to have economic effects, as well as having effects on the students themselves, particularly if they then need to catch up, if homeschooling is not as effective as in-classroom teaching. Workplace restrictions are likely to have economic effects. Requirements to work from home are a bit ambiguous. There are some industries where it appears that working from home can increase productivity, and we talked about the evidence relating to working from home in a previous video. However, note that some people simply can't effectively work from home in their jobs, so this requirement to work from home is going to have economic implications. If we look at the other ones, for example, social distancing, mask wearing, quarantine, restrictions on visits to aged care facilities, really they're going to have smaller levels of economic cost. So there's not going to be no economic cost. So for example, if we think of personal hygiene and restrictions on visits to aged care facilities, that's going to have an increase in cost for the aged care facilities. The aged care facility staff will have to have personal protective equipment. So it's not costless to do this for the aged care facility, but it's certainly not the sort of economic cost that would be associated with having to shut down a business. So we can think of these non-pharmaceutical interventions as those that have a high economic cost and those that have a lower economic cost. And really what we want to see here is to what degree do we need the more economically costly interventions in order to stem the progress of COVID-19 in this second wave, in the situation where we actually have some pretty good information about the virus. Unlike the first wave, we know now what is going on. And it's exactly that question that Barkey, Fahey, Mina and Stock, I'm going to refer to them as BFMS for shorthand, it's exactly that question that they seek to address in their paper. What they do is they use an age-based SEIQRD model. Now, before you get horrified by the acronym, this actually isn't that different from the simple SIR model that we looked at way back at the start of this course. However, it does have some differences. It's a more sophisticated model. They're going to divide the population up into 5 different age groups. So those from 0 to 19, 20 to 44 years of age, 45 to 64, 65 to 74, and 75 plus. This enables them to look at the fact that the older groups, the different groups in the population, run much different risks from COVID-19. And again, as we've already mentioned, the older age groups are much more likely to get serious complications if they're infected, including dying. As in our SIR model, the S is going to refer to those in the population who are susceptible to the disease. They haven't caught the disease yet, but could be infected in the future. The E refers to a group that we didn't have in our simple SIR model, those people who have been exposed but are not yet infected with the virus and can't pass it on. That's going to be an important group if we're thinking about testing, tracing and quarantine, because the objective there is to find people who have been exposed and to quarantine those people so that they can't pass on the virus. As with our simple SIR model, the I is going to refer to those individuals who are infected and can infect others. We're interested in quarantining, and that's what the Q stands for. That's going to be the proportion of the population who has been infected and is now quarantined. R is going to refer to those individuals who have been infected but have now recovered. And the normal assumption is going to be made here, which is that those people who have recovered can no longer be infected by the virus. As I'm making this video, there's actually been a confirmed case now in the US where somebody who had been infected and recovered was reinfected, but that still seems to be very unusual, particularly in the short term. So over the period of time that BFMS are looking at, which is about a 9-month period, I think that's a reasonable assumption to say that once you've recovered, you're not only not able to infect somebody, but you can no longer be infected. And the final element of the model here, well, some people die of the virus, and obviously once they're dead, they're not going to be infecting anyone. So while this model is much more sophisticated than the SIR model that we looked at earlier on in the course, it does have the same basic elements. And if you understood the logic of the SIR model, the same sort of logic is going to flow through to this model here. A caveat to that, however, is that the BFMS modelling is going to include endogenous behaviour change. Remember, early on in this course, we saw that the evidence showed that individuals change their behaviour endogenously in the pandemic. They don't wait for the government to act. If they think going to the local shopping mall is likely to lead to death, well, guess what? They're not going to go to the local shopping mall. So the BFMS model is able to bring in those economic elements, those endogenous choice elements, and use the data that we've been able to compile. For example, that paper by Goolsby and Syverson that we've referred to a number of times in this course, but a lot of other work also that's appeared. They're able to then include this endogenous behaviour change in the model. And that's going to be an important element in this model. Because of course, if we're looking at various interventions, the degree to which those interventions matter is going to depend on endogenous behaviour change. For example, the government could say, let's open up the economy and let it rip. If they do that, but there's still substantial virus around, well, sorry, people aren't just going to say, yeah, let's go down to the pub and club, let's go to the gym, let's get COVID-19. No. The policy itself of opening up the economy may itself not work because of the endogenous behaviour change. So the BFMS model is able to incorporate that, and that, as I've said, is really important. Finally, remember it's important to understand what the objective of the modelling is. What are we trying to achieve through these interventions? Early on in the pandemic, it was likely to be to not overwhelm the hospital system. And a strict lockdown was probably the only way to do that in the early days of COVID-19. But now that we're talking about the second wave, we really want to consider both the health and the economic costs from various interventions or lack of interventions. So what conclusions do we get from the BFMS analysis? First, they find that an economic lockdown, either a full or a partial, or more nuanced economic lockdown as they call it, is definitely not the best intervention in terms of both reducing deaths and minimising economic costs. Yes, it will reduce deaths, but it has a high economic cost. And it may actually not be sufficient to stop a second wave of infections, in other words, the virus taking off again. And before you say, well, hang on, surely an economic lockdown, a total lockdown, that's as strong as you can get. Remember, this is thinking about a lockdown without the other measures, without mask wearing, social distancing, and so on. Now, no country's actually done that. In that sense, you might say, well, is this setting up a straw man? But it's important to understand this as a base case, that just a straight let's lock down the economy but don't do anything else is costly, and it's not really as effective as we would like. So at a minimum, we want other complementary policies, such as mask wearing, such as social distancing, to go along with a lockdown. And of course, that's exactly what we've seen in various countries. No country has just done the straight lockdown without mask wearing, social distancing, personal hygiene, and so on. That makes perfect sense. And in the fact that that's the conclusion come out of this model, well, that's good, because it tends to suggest the model's in the right ballpark. Second conclusion is that these non-economic interventions can substantially reduce both the economic cost and the loss of life, particularly together with a nuanced opening up of the economy. What do I mean by that? Well, what their analysis shows is that if you have, in partnership with mask wearing, quarantining and testing, personal hygiene, social distancing and so on, if in partnership with those you have some economic lockdowns, for example, reducing very high contact activities For example, movie theatres are shut, indoor sports, other live indoor entertainment venues. If they're kept shut at the same time, then the BFMS analysis shows you can essentially open up much of the rest of the economy, but if you do so sensibly, so for example, holding in place for a while, if you can work at home, you should do so type of rules, that sort of really common sense type of approach, they show that it can be very, very effective, not only at limiting deaths, but also at limiting the economic cost. Indeed, what BFMS show is that using that group of non-economic interventions as a package of interventions in society can reduce or eliminate the need for any second wave economic interventions. In other words, if you get the non-economic interventions right, you may not need to do much in terms of forcing, for example, business closures. In some ways, this actually isn't surprising. The BFMS model is based on real-world data, and if you remember back to the last set of videos, we noticed that countries like Taiwan and South Korea had very aggressive non-economic interventions, particularly their quarantining and testing, and they had largely been able to avoid any second wave economic interventions. So in a sense, the real world suggests that the BFMS modelling is probably on the right track. But it does have some pretty important consequences for the policy for government. The first really important factor is that economic interventions are neither necessary nor sufficient to prevent a second wave. Well, not being sufficient, well, as I said, that's a bit of a straw man, because no country has just relied on economic interventions. The key part is, rather, that they may not be necessary. In other words, rather than starting with a lockdown, which was essentially what happened in Victoria, we may want to leave the lockdown and those strong economic interventions as the last tool if all else fails, and not introduce them too quickly. And the other key factor that comes out of a modelling is this one about non-economic interventions significantly helping when you want to open up the economy. So to get a strong reopening from an economic perspective, you want to keep the non-economic interventions, mask wearing, social distancing, protections for aged care facilities and so on, you want to keep them in place. The reason is because of that endogenous behaviour change. That really they're a key part of creating confidence so that people will go out and engage in economic activity. Or to put it another way, what the modelling shows is that non-economic interventions are an important and effective substitute for a lockdown strategy. And secondly, those non-economic interventions are a necessary complement to successfully moving out of lockdown. They're a complement in two ways. When you're moving out of lockdown, you want to make sure that the virus doesn't take off again. You need those non-economic interventions, mask wearing, personal hygiene, social distancing, keeping rules in place about visits to aged care facilities. You want to keep all of them in place, together with testing and quarantining, to make sure the virus doesn't take off again. But it's also got that other element of success, which is that if you want the economy to take off again, you still need to keep these interventions in place. I think we've actually got a very good example here in Australia of one state that has been able to manage these non-economic interventions pretty well, together with an opening up of, not fully, but most of their economy, and that's in New South Wales, where the number of infections has been, anywhere from 0 to up to around 20 a day, but it's been maintained at that for a number of months. Very strong test and trace regime in place, together with quarantine. not of the Taiwan, South Korea type variety, but within Australia's privacy laws. I think the comparison to Europe is important and informative, where in general they opened up significantly going into the summer holidays there, going into July and August, allowed a lot of social activity, and they're now in a second wave and they've started locking down cities and countries again. And unfortunately, I think that's a reflection of their failure to understand how these interventions, these non-pharmaceutical interventions, fit together, and that you have to manage the risk to both limit the deaths and to limit the economic damage. Finally, whilst the modelling that we've gone through here is just one paper and one particular model, it is part of a growing view around the world that lockdowns are perhaps not the best way forward with the second wave of coronavirus infections, but rather we have to think about learning to live with the virus. Here's an example of that by David Nabarro, who's with the World Health Organization. His article, Reflections About the Middle Path, argues that there are three key interlinked emphases that are needed to deal with this second wave and ongoing threat of COVID-19. These three emphases are, firstly, that people are encouraged to adopt all precautions all the time. What that means is that physical distancing, proper face masking, hand, cough, surface hygiene, self-isolating when ill, shielding those most at risk, that those non-economic interventions are carried out all the time. Secondly, the importance of test, trace, isolate, protect services everywhere. So that means that there's testing capacity to pick up where the virus is, to detect spikes, to manage surges, to make sure we've got that testing and tracing capability in place to ensure that we can stamp on the virus before it spreads. And the third emphasis is this clear and consistent messaging, making sure that people aren't confused, that people get a clear, consistent message about the importance of these first two elements. And it's interesting to note that Nabarro basically says that lockdowns really aren't the way to go in dealing with COVID-19. And I think that's going to become more evident as we realise that we have to live with this virus going forward. Yeah, it's fine to hope for a vaccine, but what if a vaccine doesn't come? Or its mass distribution is only at the end of 2021? Or if, a bit like the annual flu virus, sure, we get a vaccine to this variant of SARS-CoV-2, but there can be mutations down the track that mean that every year we have a coronavirus season. We need to think about how we go forward to create a safe community that doesn't involve the excess economic costs associated with lockdowns. So that's it for this week. Thank you for listening. Next week we're going to focus in on testing and the importance of different forms of testing and how different types of tests, which up till now tend to have been viewed as alternatives, as substitutes, how they can really work in a complementary way to deal with this second step, improving testing, tracing, isolating, protecting services. But that's for next time. Thanks for listening. Talk to you then.